In this section of Chapter 6, we're going to talk about bronchodilation. If we have an animal that's having difficulty breathing, we would want to dilate the bronchioles to help them breathe. But we're going to talk first about how bronchoconstriction occurs. And this little picture illustrates what it is. So here's our normal bronchus, and this is bronchoconstriction. Now, in a normal animal, we have a little more dominance in this area of the parasympathetic nervous system. And the parasympathetic nervous system, our rest and restore system, causes a slight amount of bronchoconstriction. When an animal is stimulated, then the sympathetic nervous system, via epinephrine and norepinephrine, is going to stimulate receptors that then cause the bronchioles to dilate and help an animal to breathe in a situation where they're running away or fighting. So, bronchoconstriction is caused by the parasympathetic nervous system. We have three mechanisms of bronchoconstriction. We've talked about one here, but there's a couple others. And it's important to understand how it occurs so that we can understand drugs that basically may counteract a particular mechanism. So the first way that bronchoconstriction can occur is via drugs that stimulate the release of acetylcholine. So acetylcholine is the neurotransmitter of the parasympathetic nervous system that's going to cause that bronchoconstriction. The other way that can happen is that we get this inhibition of release of an enzyme called acetylcholinesterase. Acetylcholinesterase is basically responsible for destroying acetylcholine. So it only hangs out for a certain amount. It is then destroyed via this enzyme. And so if we inhibit the release of the enzyme that destroys the acetylcholine, we're going to have the acetylcholine hanging out longer, and that's going to cause further bronchoconstriction. And this last mechanism, the inhibiting of this enzyme that destroys acetylcholine, is how organophosphate insecticide toxicity occurs. It's just going to cause an excessive parasympathetic nervous system stimulation and causing difficulty in breathing. So the second mechanism is the release of histamine. We know that histamine is released in reaction to inhaled allergens, and that will cause this bronchoconstriction. And in cases of asthma, we get even further bronchoconstriction, and may need to use what's called a rescue inhaler, something that will help us to allow that animal to breathe right away. So histamine released from allergic reactions may cause this bronchoconstriction. We have found that it's not the only thing responsible. There are some other mediators such as serotonin, prostaglandins, can also, and leukotrienes can also cause bronchoconstriction. But histamines are a main player, and they hit on these H1 receptors in the case of the lungs. It's important to note that mast cells, which help release this histamine, can also change mucus viscosity. So we may have a problem with getting mucus out in a situation where if we're having trouble breathing and then we're collecting fluid and mucus in the lungs, that's very not desirable. So we might have to treat that at the same time. And then bronchoconstriction can occur with drugs like propranolol. Remember propranolol? LOL means basically it's a beta blocker. So propranolol, we talked about it back in the antiarrhythmic drugs. Propranolol is the non-specific beta blocker, and so it blocks both beta 1 and beta 2 receptors. What we really wanted it to do in the case of cardiac drugs and treating arrhythmias is we want it to block the beta 1 receptors, the ones responsible for heart rate and contraction. But it also, in the case of propranolol, it also blocked beta 2 receptors, which then caused bronchoconstriction, which is not a desirable thing in an animal that may be having a heart problem. We want them to be able to breathe as easily as possible. So, propranolol will cause the the parasympathetic nervous system to predominate because it will slow heart rate and it will also cause vasoconstriction. So that's how we can get another method of bronchoconstriction. So let's look at bronchodilators. We're going to talk about beta adrenergic agonists. So these are agonists that are going to stimulate beta receptors. We're going to talk about selective versus non-selective. So remember the beta 1 receptor, if we stimulate it, it's going to increase heart rate and contraction. Beta 2 receptors, if we stimulate those, we're going to cause bronchodilation. Stimulation of these receptors is what happens with the sympathetic nervous system, which is going to be the effect that we really want in the case of the lungs. We would prefer these drugs to not act on the beta 1 receptors. We don't need an increase of heart rate and force of contraction unless we're treating that particular situation. But if we just have a respiratory problem, we would rather just treat that and not cause stimulation of the heart. So, types of bronchodilators. We have alpha and beta agonists, such as epinephrine. We have some older beta agonists, isoproterenol. And we have some selective beta 2 agonists, terbutaline, albuterol. And then we're going to talk about methylxanthines, which include theophylline, caffeine. That's why we have our little happy chihuahua up here worshiping coffee. And theobromine, we've talked about that, right? We've done a lab on chocolate toxicity, and that's the main ingredient for that. And aminophylline. So the first drugs we're going to talk about are alpha and beta agonists, and epinephrine is our prime drug for this. So alpha and beta effects are things such as vasoconstriction. So that's the alpha ones, remember, that cause vasoconstriction, shunting of blood away from the skin, getting it to the core where we can use it for running away or fighting. Increased heart rate, cardiac output, and contractility. Now we're really wanting the effect of the bronchodilation. But these other side effects are part of the reason why we don't use epinephrine as a vasodilator. It is used in emergency situations. It's a very good bronchodilator. And so if we are having trouble breathing, we're going to use epinephrine as a sort of rescue drug. We also have non-selective beta agonists. Isoproterenol is that drug, and we don't use this drug as much as we used to because it does have significant, it's non-selective, so it's going to act and be an agonist on both beta 1 and beta 2 receptors, so it's going to increase heart rate through the beta 1 stimulation. If we give it via inhalation, we don't tend to have that heart rate effect anymore, so as much. So we can use it via an inhaler. But we would prefer to use beta 2 agonists, the ones that are selective for those receptors. And terbutaline and albuterol are two drugs that do just that. With the first few doses, we might see some stimulation of beta 1 receptors, but usually that goes away over time. We can use these drugs orally, we can use an inhaler, and a specific type of inhaler is a metered dose inhaler. So something like this, and this horse is being very patient to just have that be put over their nostril. I think those muzzle ones are a lot easier, but this is a little metered dose inhaler. It's delivering a specific amount. And we can also give these drugs sub-Q. Terbutaline has an additional property to it that makes it more desirable in that it will reduce mucus viscosity. So it helps us to get rid of mucus that's gotten sticky over time. So this is another way where we can go up the nostril in a horse. Not every horse is going to tolerate that. So the muzzle ones are better, but this does get it further down into the airways. So methylxanthines, and these include caffeine and the related compounds of theophylline, aminophylline, and theobromine. And the way that this acts, your book goes into great detail about it. I'm not that interested in you knowing what the mechanism is because over time, the first edition of the book or the second edition that I used mentioned one way, the next edition, the third edition mentioned another, and this last edition is saying, might be both of the mechanisms. Basically, when we have beta 2 receptor stimulation, we get production of something called cyclic AMP. Cyclic AMP causes the relaxation of smooth muscle and bronchodilation. So that's our effect that we want, that beta 2 receptor stimulation. And the cyclic AMP is broken down by phosphodiesterase. So here's another enzyme. We think methylxanthines may work to block this phosphodiesterase and therefore will leave more of the cyclic AMP, which causes the relaxation of smooth muscle and bronchodilation. And so that is maybe how it works. But we also think it may block access to calcium. And calcium, if you remember, can cause bronchoconstriction. So if we don't have as much access to it, it's going to therefore allow those bronchioles to relax. Again, I don't care that you know that, but the book seems to want you to know and makes a lot of production about it. But basically, we've been trying to figure this drug out for a while. This group of drugs out, I should say. The main drug that we use is theophylline. And theophylline is used for recurrent airway obstruction. RAO is the acronym for that. It used to be called COPD, which stood for chronic obstructive pulmonary diseases. This is a disease in horses. We can also use it for tracheal collapse in dogs and asthma. And part of the reason why it is a more popular form of this group of drugs is that it occurs in sustained release oral forms. We need to be careful in using those forms because it can pass through the animal without having been absorbed. And so usually a veterinarian will find a particular brand that they like and they'll stick with that one. They'll just go with it because they know that it will be absorbed and be useful in the animal. In horses, the drug has a narrow therapeutic index. So we need to be careful with that because we can get toxic values pretty easily. And the side effects, main side effects are central nervous system stimulation and GI upset. That's usually transient with the first few doses. Because of that central nervous system stimulation, this is a substance that on the racetrack they look for this. It is a drug that they don't want horses to have. The big thing about theophylline and methylxanthines in general is they interact with a wide variety of drugs in a variety of ways. So it's really important in using these drugs to be sure that they can be used with other drugs if there are other things being treated. So that I'm not going to get into the specifics because you can read that, but you just need to be aware that these drugs interact with other drugs. Lastly, aminophylline is a salt of theophylline. It contains about 80% of theophylline. We just tend to use theophylline, but because aminophylline is out there, I wanted you to be familiar with that term.